telehealth in rural communities, put on in partnership with the NRTRC and Comagine Health. It is my honor and pleasure to introduce Trudy Bearden. She is the Senior Consultant in Telehealth Lead for Comagine Health. She has a background as a clinician managing and practicing primary care health centers. So without further ado, I'm going to hand it over to Trudy to get us started.
Thanks, Nikki. Greetings, everyone. We have a small and cozy group today. So this webinar is kind of taking the place of office hours, but I hope that we can have get some discussion going, because this may be the NRTRC and I may be the telehealth lead, but you all bring knowledge and experience to the discussion as well. So I hope we have a chance to actually talk to each other in a bit. It would be great if you can type your name into chat with your role, your organization, and what do you think is the biggest telehealth barrier in your rural communities? I think we can probably predict what your responses are, but we would love to hear from you. What are you seeing in and around your rural communities as the biggest barrier to telehealth, both for patients, clinicians, organizations as a whole? What do you think? So today we'll talk a little bit about options to optimize remote service delivery. And because I am a clinician and I work with health centers, rural health clinics, academic medical centers, all types of organizations around improving healthcare service delivery, I love that we now have telehealth in our toolbox. I stray a little bit from the, I color outside the telehealth lines, I would have to say, when I think about remote service delivery, because I want to think about everything that we can do for patients to deliver our services remotely if it's going to improve outcomes, per beneficiary cost, patient satisfaction, and the work life of staff, AKA the quadruple aim. We'll talk about some potential community solutions to some of those barriers in the rural communities. And this is where I think that those of you on the line may have some input as well. It's okay, I'm not going to make you chat. If you just want to sit there and listen, that's fine. And then cover some of the key components for sustainability for telehealth. So there are factors that have to do with rules and regulations. There are factors with the culture of clinics. There are factors whether we can have an audio only option. So we'll talk a little bit about what those options are. So here's kind of my world of remote service delivery options when I think about primary care primarily. So other disciplines can certainly use all of these remote service delivery options, but I confess to having a little bit of a primary care lens, and I'm really, really sorry if those of you who are on the line are not in primary care, and if that, my bias comes through too much. I would say slap my wrist, but you know, we're in a virtual world, so no can do. So I really think about it as telehealth services, which are with healthcare service delivery is defined by that discrete set of about 250 codes that Medicare comes out with every year. There's 250 codes now because they've added a bunch due to the public health emergency. When that ends, we're going to see that list shrink to about 110 codes. The services almost have a one-to-one relationship for all of those telehealth services defined by those codes and services. Those services could also be furnished in person. So there are office visits that are telehealth, there are office visits that are in person, but they use the same codes, the same services. There's always, with telehealth, there's always a distance site, that's where the provider is, and there's always an originating site where the patient is. And when you're doing telehealth, it's a good idea to think in those terms. I know that around telehealth, there's sometimes, you know, our special language, and distance site and originating site has to be part of that lingo. And except for the public health emergency, all telehealth includes both audio and video components. If you go to that list of 250, kind of that expanded discrete list from Medicare, they identify which ones can be done audio only. And then there's virtual care services or remote service delivery. There's the telephone evaluation and management, which is like an office visit, but on the phone with your clinician. This has been key for our rural communities to deliver remote services, or, we can kind of put it under telehealth, but this phone option is really important. There is legislation that is on its way through to ensure that we have an audio only or telephone option at the end of the pandemic. However, there are serious concerns about fraud, apparently. There are schemes to create fraud using the telephone evaluation and management and other telehealth services, and that's getting the attention of the OIG, the Office of the Inspector General. And health plans are a little reluctant to pay for a telephone call at the same rate as they do an in-person visit. So payment parity. Currently for telehealth, Medicare and most, if not all, Medicaid agencies reimburse for telehealth codes the same as in-person codes. So I really don't think if we do get that in place, I don't think we're gonna have payment parity. Remote physiologic monitoring is one of the virtual care services that has the most evidence behind it to reduce emergency department visits and admissions. And yeah, that's great for reducing per beneficiary costs, but you know who else it really matters to? Patients. So we can touch a little bit on that in a minute. Virtual communication services comes in two flavors. There's the virtual check-in, which is 5 to 10 minutes. Usually it needs to be patient initiated. There is a code through the end of the year that allows a virtual check-in that's 11 to 20 minutes, which is great because you know what I hear? It's another audio only option. And then the remote evaluation of pre-recorded patient information, which could be, for example, a patient sending you a picture of a rash or a bruise or a cut and saying, hey, what do I need to, am I okay? Do I need to come in? Is there something you would recommend? I think this is going to be a really great option for patients who are immobile and may be developing skin breakdown, and you don't want to be moving those patients and bringing them into the office. I think this is a great option. There are the e-visits, and I have to say that most of the rural practices that I work with are not taking advantage of this because it requires it's an online digital experience, so think portal. And now here's where we stray really far away from what usually is covered under telehealth, and that's the chronic care management and the principal care management and the behavioral health integration codes and services. But it's an amazing option for monitoring patients and being able to talk to patients on a monthly basis, especially in our rural where patients are a long way off from clinic. And then the Psychiatric Collaborative Care Services really offers, it's called the Collaborative Care Model, and it does require a team of individuals, and you do have to have a psychiatric consultant. So it rules it out for a lot of practices and clinicians and patient options. I do hope and wish that state Medicaids will pick up on the collaborative care model, and if only they would provide us a psychiatric consultant, we would be able to expand the collaborative care model and expand mental and behavioral health access for our patients. And then there's the interprofessional consultation option, which I just don't hear a lot of people talking about or using, and I feel as though it is something that is essential for expanding access to specialists in our rural communities. So that's a really quick little rundown on what we can cover. So now that you heard that kind of rundown, if we spend a little bit of time taking a deeper dive into some of these options, which ones are of most interest to you? So I don't want to go through, for example, I don't want to talk about e-visits if you are like, it is a snoozer and you could not care less about this. So if we kind of have if we ask you what Oops, almost launched the wrong poll. Hold on one second. If I launch this poll and I ask you to let me know which, if any, would you like to hear more about? So do you want to hear more about strictly telehealth, or learn a little bit more about the telephone E&M codes, which I think most people are pretty familiar with, or dig into remote physiologic monitoring? I was talking about remote physiologic monitoring on a webinar a couple of weeks ago. We had a lot of people on that call. It was closer to 250 people, and people got really excited about remote physiologic monitoring and thinking about in the rural settings, like how can you do that? So if you're a health center or a rural health clinic, Medicare will not cover remote physiologic monitoring, and then our state Medicaids are like all over the board with how and if they cover remote physiologic monitoring. So let's see. Looks like we have telehealth itself, so we'll cover that, the E&M codes, RPM, virtual check-ins. So pretty much, how about if I just look at what we're not interested in? So remote eval, we can whiz over e-visits and interprofessional consultation. We'll just touch on those really briefly if we have time, and if not, we just won't go over them. Great, thank you so much for chiming in. And because I'm a little sensitive to the fact that I sometimes take too narrow of a lens, I just want to throw out the reminder that it's not just about primary care. It's not just about that discrete set of Medicare services. So telehealth for rural communities can offer education and the option to present patient cases. So you've probably heard about the ECHO model. It was initially started by Dr. Sanjeev Arora many years ago around liver cancer and hepatitis C care, because in our rural areas, we don't have specialists who are GI specialists who can handle that type of care. And so I know that one of my health centers that I work with in Idaho, they rely on echo sessions, and they're always asking for echo sessions for behavioral health. So being able to have a behavioral health specialist on a Zoom or whatever and present a case. So yes, we always protect patient information, but if you have a challenging case and you might be a physician assistant or a nurse practitioner or a physician who doesn't have a strong background in behavioral health, and you don't have a bevy of behavioral specialists that you can refer to, these echo sessions or other kind of learning opportunities through telehealth are huge. Tele-dentistry is underutilized. So, we work with our health centers a lot on oral health integration, and tele-dentistry is an option that we don't think about a lot. And it can be anything from having a dental hygienist who might take a good patient history, take high resolution pictures and x-rays, and then send the information electronically to a dentist who can make a treatment plan for the patient. This is huge in our rural, not even our rural communities, but across the board. 50% of Americans over the age of 65 have no teeth left in their mouths. So we have opportunities to improve, and telehealth and tele-dentistry is great. Telestroke is also really important because time is of the essence when people have strokes. And if you're in a rural community, it's, you don't have a stroke unit necessarily. And I recently heard somebody who was working on the telestroke team at Portneuf Medical Center talk about the work that they do, and she was so proud. And they talked about measurement and time to treatment, and it's essential, especially in our critical access hospitals. Telemental and telepsych services. some patients can be going through a crisis, and it's going to take, oh, we understand you're really suffering, and you may even have a patient who's suicidal, and suicidal patients, we can usually find a way to get them in immediately. But other patients that are having mental crises, sometimes they're told, okay, fine, but you're going to have to wait 3 months. Not helpful. And I think we have so many opportunities to really think about telehealth in our rural communities, identifying what the needs are, and then finding ways to meet those needs. So telehealth is, when we think about substituting for in-person visits, telehealth is really defined by that list of codes on the Medicare list. It's an Excel spreadsheet. It gets updated all the time. So I just looked yesterday, and it was last updated March 9th. They don't tell you what they changed, and there's like 250 codes. But in there, it lets you know which ones you can do audio only, and some of them are really interesting. So providing advanced care planning for patients is a telehealth service, and even more important now because we're in a pandemic and people are dying. And you can do advanced care planning by audio only. You can do a annual wellness visit for Medicare patients, audio only. Office visits, however, so the codes that match, say, an established or a new patient, the level 1, 2, 3, 4, 5 codes, those are need audio and video. But that list lets you know which ones you can do audio, which ones you have to do audio and video. And of course, as I mentioned before, you have a distant site where the provider is and the originating site where the patient is. So if you're a rural practice and you are delivering telehealth services to the patient in their home, the distant site is your clinic. The originating site is the patient's home. However, if the patient is at your clinic and you arrange for a telehealth visit with a specialist, the originating site is where the patient is, and that's at your clinic, and the distant site is wherever that specialist is, which could be within your state or could even be outside of your state. Thankfully, geographic restrictions are lifted for the public health emergency, and there is legislation in the works to keep those permanently lifted. Previously, depending on where the originating site was, the originating site had to be in a designated rural area and in a health professional shortage area, which is silly. We have health professional shortage areas in urban areas as well. And for about 90 of those 250 codes, audio and video is still required. The reimbursement for Medicare patients is the same, like I mentioned before. For federally qualified health centers or FQHCs and rural health clinics or RHCs, CMS for 2021 has bumped up the reimbursement a little bit, and we are now at $99.45. Your actual reimbursement will be different, but this is what they call the price, the kind of the national payment price across the board. And then for the state Medicaid agencies and other insurers, payment parity may not be in place. I think most of our state Medicaid agencies do pay parity. And then during the pandemic, some of the states have stepped in and said that the commercial health plans have to reimburse at parity as well. So that's all good. So that national payment amount for the non-facility price, you're going to see a bunch of prices, and some of them are current as of March 16th, and some of them are not. The site is down, and I can't get to it. So before we send these slides out, I'll make sure that all of the prices are current. But from one quarter to the next, things really don't change a lot. There might be like $1 or $2. I did see one that had changed by $6, and it was actually on the upside, so increased reimbursement by $6, but usually they stay the same. So when we think about, especially for primary care, these are some of the high yield services that we should and could and can be delivering, especially in the pandemic. So we can do all of our office visits by telehealth. And you can see what the reimbursements are for the codes for the new and established office visits or evaluation and management visits or E&M visits or E&M codes. For the FQHCs, it's always, for any code, the reimbursement is going to be $99.45. And I did receive a question a few weeks ago, can an FQHC or an RHC bill say, we're going to do advanced care planning and we're going to do an E&M visit? And even though CMS doesn't flat out say you can't do that, some of the way they talk about whether you can or cannot bill a behavioral health visit in addition to an office visit suggests to me that no, you cannot do that. So you can do advanced care planning. So if you're an FQHC for either one of those codes, you get reimbursed $99.45. But if you're not an FQHC or an RHC or a tribal clinic, the reimbursement is great. And advanced care planning is huge. It's so important now too, especially for our older populations who may have been what we call do not intubate or do not resuscitate. And they may change their minds. They may say, oh, wait, if I get COVID, I do want a ventilator. So if I were a clinic, I would look at all my patients 65 and older. And if they didn't have advanced care planning in place, I would start doing this by telehealth. You do not have to have advanced directives done, but I have also worked in the inpatient setting. I worked on the vascular surgery service at Yale New Haven Hospital. And because we were a vascular service, we had a lot of patients die, and a lot of them had no advanced care planning in place, and it tore families apart. It was terrible. So I beg you, please, if you have older patients or patients who have a lot of chronic conditions, make sure advanced care planning is done. Sorry, side trip there. Transitional care management is also really important for patients who have been discharged from the hospital. This is where bad things happen to patients because the transitions from the hospital to home are just fraught with errors. And I know because I've been on both sides. I've discharged patients from the hospital and I have cared for my own patients who are discharged from the hospital. These codes can be delivered by telehealth and they are underutilized. And because of that, CMS keeps bumping up the reimbursement, which doesn't help you if you're an FQHC or an RHC. But you can see that if you see the patient within 7 days of discharge, you can charge, $188 to $250. I mean, we should be doing this, not only because it's the right thing to do, but because we can do it and because there's reimbursement behind it. So those initial and subsequent annual wellness visits, which I told you about, those don't have to be all the clinicians' work either. So RNs for both transitional care management, advanced care planning, and transitional and annual wellness visits, RNs and other staff can conduct a lot of the elements that are required, and we have some resources for you. All of our patients, especially Medicare patients, they have a benefit to receive diabetes self-management training and medical nutrition therapy. So they get 2 hours of each every year that Medicare will pay for, but only 5 to 10% are actually referred for these services. Diabetes is hard enough to manage. I tried to live a day in the life of a person with diabetes. I made it to 1 p.m. It's hard, and this is their benefit, and we should be referring them if we can possibly provide these services. There's a lot involved to that. We should be doing it. The same for chronic kidney disease, patient education. Counseling to discuss the need for lung cancer screening using low-dose CT scan. I heard that CMS is doing away with this code, but I looked it up the other day in the lookup tool when it was working, and it's still there. And oh, by the way, they just lowered the age for lung cancer screening. I think screening starts at age 45, so you even have a larger population who you should be looking at whether we should be doing this counseling and talking to patients about whether they would like to get this low-dose CT scanning to catch lung cancer early. And then there are so many codes and services for treatment for opioid use disorder. And this doesn't even include the codes that have been added. There are a lot, like providing services to patients in their home. So There was interest in the telephone evaluation and management codes. So if you're an FQHC or an RHC, you just bill that G2025 code. And if you're not an FQHC or an RHC, you have a whole set of additional options. And I will say that for these telephone evaluation and management, they are like an office visit, but what I'm finding is that practices are just having the clinician call the patient and then billing the code. And these are like office visits. We need to do everything we did in person. We need to do pre-visit planning. We need to identify and address chronic and preventive gaps in care. This is not just about a phone call between the clinician and the patient. I mean, it can be, but we're exposing our patients to risk. So we have implemented team-based care. I mean, we've been kind of beating the team-based care drum for so long, and then people are switching to telehealth or the telephone E&M codes, and the team-based care is falling by the wayside, and it exposes the patients to adverse events. It's a patient safety issue. So, treat these like, we have to still provide a whole patient care, especially if we're in primary care. And there are these additional options for telephone, they call it assessment and management. So if you aren't licensed to practice medicine and you don't have an NPI number, you cannot do evaluation and management. And you'll see that the verbiage is very different. It's assessment and management, and it can be provided by a qualified non-physician healthcare professional, like an MA or an RN or an LPN. And so there are these options for having full kind of team-based care and getting reimbursed for it as well. All right, so that is the evaluation and management piece. We're gonna have a chance for questions. I can't see the chat right now, but I can see we have a few things in chat. For our rural communities, remote physiologic monitoring is a huge opportunity. So if you go to the CCHP website, the Center for Connected Health Policy, and if someone can put the link in for that, that would be great. This is my favorite resource, and I go here to see what the state Medicaid agencies in the states that I work in around telehealth, whether they do or don't provide remote physiologic monitoring. And it's all over the board. If you look at the states that are covered by the NRTRC, we have Alaska, Idaho, Montana, Oregon, Utah, Washington, and Wyoming. It's hard to say. There are none of the states that offer the full range of coverage that Medicare offers for Medicare beneficiaries. I really think this is an advocacy opportunity. And I think part of why state Medicaid agencies don't have this on their radar as an amazing way for patients to have self-management support and for us to keep them out of the emergency department and the hospitals is that CMS or Medicare has never come out with a fact sheet around remote physiologic monitoring. It's just not on people's radar, like what this means. And it's huge. So if you have a patient with heart failure and they have more than a 2-pound weight gain in 24 hours, that's not because they ate a lot of pizza. That's because they're in volume overload. And if something isn't done, if you don't increase their antidiuretic, they're going to go into volume overload. They're not going to be able to breathe, and they're going to show up at the emergency department. The same is true for patients with chronic obstructive pulmonary disease. You can remotely monitor oxygen saturations. You can do it for patients with blood glucose monitoring, so that, we don't just see them every 3 months or every 6 months or once a year and then kind of play catch up when things have been going on that we don't know about in the primary care and specialty setting. So, I really feel as though there's this, so I was talking to some of my colleagues at the Idaho Department of Health and Welfare, and I'm like, why are you guys not offering this? And they're like, we're not sure. It's just not on our radar. And I really think that it would be great if across the board, all of our state Medicaid agencies would get on board with remote physiologic monitoring. And some people call it remote patient monitoring. I have to say that one of my health centers started trying to do remote patient monitoring around blood glucose. And they refer to it as remote patient monitoring. And they had patients who were like, no, nope, not going to do it. Like, I do not want the government tracking me. So I've tried really hard to steer away from calling it patient monitoring, and it's remote physiologic monitoring. And we've had other patients, our patient and family advisory folks have told us, yeah, it might be better to stick with using the terminology of physiologic, although I have to say it doesn't roll off my tongue quite as easily. I'm not sure about you. So for FQHCs and RHCs, unfortunately, Medicare considers this part of your all-inclusive rate. So it's not that you shouldn't be doing it because you don't have separate reimbursement for it. And Medicare says that they will re-look at this in future rulemaking. I think the case can be made that it's about time. I mean, they can add that to the suite of care management codes and services that they define for FQHCs and RHCs. But, can you add that into the chronic and principal care management? I say yes. And I think I told you earlier that I was on a webinar and I mentioned this as a possibility. I have health centers that are looking into this as a possibility. And I actually had a lovely conversation with an administrator over 7 community health centers in Connecticut because he wanted to learn more. He's like, what are you thinking about with like including RPM into CCM? Yes, the acronyms were flying about. And then, there are things around remote patient monitoring, remote physiologic monitoring that CMS would not pay for. So self-measured blood pressure is an option. And, somebody takes, they take a blood pressure log and they email it to you, for example. That's one step away from collecting data with a Bluetooth-enabled device like a scale and then sending that data electronically to the clinician or the care team. But, again, I kind of want to be as inclusive as possible to expand the range for our rural communities to really care for patients. There's a really great FQHC, RHC remote patient monitoring kit. The AMA also came out with a playbook. They have it. It's a really long title, but it's really about remote physiologic or remote patient monitoring. And one of my colleagues was one of the authors of that. And because there are not these kind of robust resources from CMS, we've created this kind of compilation of everything since, I don't know, over the past 2-3 years. So since 2019, this is our compilation of everything. If you're not into reading, 3 font in CMS final rules, this should be your go-to resource, and we can share it out if anyone's interested. It's a lot of information, so maybe too much information, but basically remote patient monitoring starts with setting the patient up with the machine, collecting the data and getting it transmitted. It gets to the clinician or the care team where the data are analyzed and interpreted. And then the clinician or care team comes up with a treatment and a management and treatment plan. And then you keep working on that plan until the patient is at their targeted goals. So maybe a patient with an A1C of 12, we want to get them down to an 8, ideally to a 7, but we have to be realistic. And CMS calls this an episode of care. So we have this table with all of the codes and the approximate reimbursement, which is not helpful if you're an FQHC or an RHC. I get that. So I'm going to just kind of scroll through, but you can see that there are ample opportunities to provide these services and be reimbursed. And we stuck in, even though technically not RPM, if you talk to Medicare, but what are some of the other options for patients that you might get reimbursed? So if you're interested in that, just put it in the chat, and when we send out slides and recording, we will include it. All right, so the virtual communication services, so the virtual check-in, there was some interest in talking about that a little bit more. These have to be initiated by the patient. So, how can it be initiated by the patient if the patient has no idea that this is an option? So I kind of feel like we have to get the word out to patients like, hey, we have this new option. So I'm sorry, I got hung up by a typo on my slide where it says $2 for G2012. It's actually $24 or closer to $24. So, get the word out. And honestly, the most effective to get the word out to patients is honestly when clinicians are in the exam room and they message something like the patient portal or, a new program like chronic care management. But reception staff can also let patients know, and they can say, hey, we're going to get you scheduled for this appointment, but if anything happens in between, we have this virtual check-in option, and here's how you do that. Otherwise, I just kind of feel like, what are we doing with this code if patients don't know about it as an option to actually have a live conversation with their clinician or care team, which depending on clinics can be a really hard thing to accomplish. I was a clinical manager of a safety net clinic, and honestly, I felt like our clinic was just an amazing stonewall for making sure the patients could not actually talk to a real live body when they need one. So the blue font are things that were added for opportunities, options that were codes that were added for calendar year 2021. So remember with the telephone E&M codes, there was this evaluation and assessment option. And what CMS is recognizing is that for the virtual check-in, it may not just be the clinician, the MD, the DO, the PA, the NP who is going to be interacting with the patient. And so this is by a qualified healthcare professional, again, who cannot report evaluation and management services. There was very little interest in remote evaluation of recorded video and or images. So I'm just going to say this is a great option that is underutilized. My daughter sends me pictures of cuts and scrapes all the time. She calls me Dr. Mom. I'm not a doctor. I'm a physician assistant, but it can be a really great tool. I think one of the issues is it has to be secure. So how do you send it encrypted? And I've heard back from clinicians and care teams. They're like, okay, so the patient sends this to us. Like, where do we put it? Do we upload it to the patient chart? Do we have, so there are some issues, but I do think it's a pretty decent option. So very little interest in that from our poll, and very little interest in e-visits as well. So I'm going to gloss over this one. So it's really, again, you have kind of the online digital evaluation and management, but then there are these codes that were added, oh, by the way, for the non-physician healthcare professional like RN, MA, nurse. I think this is a way to get reimbursement, honestly, for social worker work, which is sometimes hard to get reimbursed, and other professionals like pharmacists who are part of our care team. But not a lot of patients are using this. I'm not even working with any practices that are using e-visits, but it is an option. There was some interest in the chronic care management, principal care management, and behavioral health integration. For FQHCs and RHCs, the reimbursement for 2021 is now $66.64, about $1 less than it was in 2020. But hey, it's still an opportunity for connecting with patients every month if they qualify for CCM or PCM or chronic care management or principal care management. And starting in 2021, FQHCs and RHCs can do chronic care management or principal care management. So that to me is huge. And there's enough money to be made in chronic care management that there are vendors who will provide the care management services to your patients. And then they'll keep a piece of the pie, of course. I think that unless you have a huge number of Medicare patients, most practices can pull this off. If you dig into the details of what's required, people get really intimidated. It's not that big of a deal. You can do it. CMS is currently looking for the CCM codes I don't think they have enough data for the PCM codes, but they have looked across the country, and they are identifying states and areas where there is low uptake of CCM. I think if they want better uptake on CCM, they need to up the reimbursement for our FQHCs and RHCs personally, but it is what it is. And this is phone only. You know, we keep saying we need a phone only option. We need a phone only option. We actually have a bunch of options where we can provide services to our patients by phone. And these are 3 of them. And for our, I'll show you so there's a lot more reimbursement if you're not an FQHC or an RHC, but even if you are, this is a great option. Behavioral health integration is the same, 20 minutes per month for individuals with mental health or substance use disorder. So to qualify for chronic care management for Medicare, you have to have multiple 2 or more chronic conditions expected to last at least 12 months. CMS says that is 2/3 of your Medicare beneficiaries. And I think maybe that's true, but you know, you could do back of the napkin calculations. Okay, our Medicare population is 1,000. If we take 2/3 of that, we have, you know, about 670 times $67 per month. You could do a back of the napkin calculation, but the reality is that, you know, it's probably going to be less than that. And not every patient is going to need services every single month. And you can't just call and chit chat with patients. You know, they truly need to have these chronic care management services to deliver them. I will say that it's not what I typically think of with care management. I think it's a mix of care management, care coordination, and chronic disease management. Just doing a time check. I need to move a little faster. So these are, if you're not an FQHC or an RHC, these are all of the options. And when you have these codes, you will have all of this very busy information, but this is kind of your full set of options for delivering chronic and principal care management. Really, really underutilized. And we do have a resource that we could send out, but it's really busy, and I'm not sure that it would be terribly helpful. And in the slides, you will also have all of these resources to refer to for CCM. And CMS has not developed resources around principal care management, but basically it's like a one-to-one walk for what you have to do. The behavioral health integration and psychiatric or collaborative care model, we have some resources for you as well. So if you're an FQHC, you know, it's that $67 per month, but the reimbursement, even for FQHCs, is higher for the collaborative care model. It's a really, really great model, and these are live links. So when you get the slides, you will be able to get to that information. Interprofessional consultation, you know, is just underutilized. It is kind of like an e-consult, but the specialist has to provide a verbal and a written report for that one set of codes, or just submits a written report, and it's based on information that the treating physician sends to the specialist. All right, so we reviewed the options to optimize remote service delivery. These are some of the telehealth barriers and solutions that health centers, et cetera, have implemented. So connectivity, lack of internet or connection or data plan is huge. We have several options listed for rural communities to think about. Providing prepaid phones. The programs to help pay for internet are great. I know some health centers provide mobile hotspots that they will drive near a patient's home so that that patient can actually engage in a telehealth visit. And the biggest one, I think if there's any message for this entire webinar, is that we can work with local community to find community-based places where patients can go, where they're going to have everything that they need to engage in a telehealth solution. And I think employers are a great place to start, because the other benefit for them is that their employee is not taking off to go drive to an office visit. And then lack of broadband in the patient's location, you know, a lot of the same things. Wouldn't it be awesome if for all of our states we could build this map? So let me kind of walk you through it just a wee bit. So if you see those purple stars, those are all health centers. This is the state of Massachusetts. I got this slide from a colleague of mine who works at the, who is actually a leader at the FQHC, at an FQHC organization. The blue stars are health centers. The little circles around them are a 5-mile radius. And then each one of those dots that look like, I don't know, bacteria growing in a petri dish, are households that do not have a broadband connection. So if you look at all the space between the circles, those are people who have decreased access to healthcare services, either by going in person because they have to drive away, or because they can't engage in telehealth. So lack of a phone or a data plan to talk on the phone, prepaid phones are usually the solution, or calling patients at the beginning of the month. Having a device with camera and microphone, you just have to be creative. And some people are mailing a device to the patient, having the patient return that device. That's a scary proposition. But again, if we could direct them to nearby community-based locations, that's a great solution. Low digital proficiency, I prefer to call that low digital proficiency rather than digital illiteracy or something like that. You know, we can get our patients up to speed. So they may have low digital proficiency, but we can help them get to where they need to be with their proficiency. We just have to have that in place. And then on the patient side, there are needs that we can help them overcome. So if they have cognitive impairment, we can find solutions. If they need translation, we can find solutions. If they are hearing impaired, we can find what works for them. Some patients say that when you speak louder, it's not helpful, but you can trial that and just speak a little louder and say, you know, is that helpful or not? And then they need to be in a private, quiet place where, you know, they may not want somebody else to hear what they're saying. And then homelessness, which most of my health centers are actually bringing devices to people who are homeless, or bringing it to the homeless shelter, which seems to work pretty well. All right, so whirlwind tour. I'm going to show the next slide, but I think what I'd like to do is, you know, just taking a peek at the time. We have about 12 more minutes left. And if that time is taken up by discussion, I think that would be best. Jillian, anything that you can kind of summarize and bring forward around what's in chat that I may not have seen, or questions that I may not know?
I think most of the questions so far, Nikki was able to answer.
Great. Good.
Yeah,
anyone on the line that like to chime in on how you've been finding community-based solutions for our rural communities?
I think if there isn't any other discussion points, Trudy, you could just go ahead and finish up with the presentation, or as Jillian said, people can feel free to unmute themselves and share their question.
Yeah, just go ahead and interrupt me. I can stop pretty quickly and pivot to a discussion. So I'm finding that one of the key changes for telehealth sustainability is an organization's telehealth perspective. So I talked to some organizations and some clinicians and some patients who say, telehealth, fine, while I have to do it. But as soon as this pandemic is over, I don't want to do telehealth anymore. I have even heard stories about clinicians apologizing to patients, like, yeah, I'm really sorry that we have to do this, but you know, during the pandemic. So if that's the perspective, I don't see telehealth being sustained. If leadership and clinicians and care teams really feel like this is a solution for patients who need and want it, it's gonna be sustained. Some health centers and rural health clinics have asked me to help them build telehealth into their strategic plan. Those organizations I know will sustain telehealth because they're looking at like, how do we keep the workflows? How do we keep the scheduling? What's our budget going to need to be? Clinicians and staff buy-in. I was working with a rural health clinic that until about a month ago, there was a clinician who was like, yeah, I'm not doing telehealth. No. And, the IT person would ask him, on a regular basis, hey, can I help you with telehealth? He's like, no, I'm fine. And then he just did a 180 and he's ready to go. But unless we have clinician and staff buy-in, it's really tough. Training, I get questions about training all the time, and the NRTRC has great training opportunities on their website, truly meeting a need. And, I've gone through the training and I think it's stupendous. I've gone through 2 out of the 3. There's one that's a behavioral health one, which I haven't gone through, but they are really, really great. Even if you're not in the state of Washington, the Telemed for training for Washington clinicians is really, really great. We are going to have parity, so the coverage parity, so health plans having to cover all of those codes that Medicare has in the list would be great, because now they kind of pick and choose about what they will and won't do, and what they will and won't make for payments. I think payment parity needs to be in place, and there's legislation in the works to ensure that that will happen. The rules and regs have to continue to foster telehealth. So our FQHCs and RHCs need to continue to be distant sites. I just don't even know why this ever happened, because if ever there was a type of clinic or healthcare service delivery, it has to be our FQHCs and RHCs have to continue to be able to deliver telehealth, not just receive telehealth for their patients. And we need to get rid of that whole geographic piece of you have to be in a designated rural area, a designated health professional shortage area. And luckily, legislation is working its way through to make sure that happens. Team-based care, if we don't have team-based care, bad things are going to happen to patients. We're going to have lawsuits. Patients are going to suffer. We're going to get regulated to the point that, personal opinion, we might get regulated if we don't have team-based care. Just really remembering, even with telehealth, that the clinician needs to do the history of present illness, any physical exam that you can do the assessment, do the plan, and do the prescribing, and pretty much everything else well-trained team members can do. And we need to, just make sure that this happens, because if things if everything that we have to do for every patient who comes in the door starts falling back on just the clinician's shoulders, telehealth is just not going to be sustained. And we have to make sure that we define value from our customers' perspective. So I worked with some health centers in Los Angeles, and they were doing telephone E&M visits, and their no-show rate was 5%, which is amazing, because even in-person visits, their no-show rate was 30%. When they switched to telehealth requiring audio and video, their no-show rate shot up to 50%. And what that says is that it's not of value, or there are too many barriers to make it worthwhile trying to do telehealth. So we have to put ourselves in our patients' shoes and make sure that the workflows are easy for our customers, and just really define value from their perspective. Workflows are really important. We have to make sure that our workflows ensure efficient, equitable, quality, and safety practices for our patients. And then the quality assurance piece is making sure that everybody has the same high quality experience with telehealth. So it doesn't depend on who the clinician is. It doesn't depend on, what type of insurance you have. We need to make sure that everybody has a high quality telehealth experience. And then quality improvement, like we need to measure what matters. And there's a lot now in the works to identify whether telehealth versus in-person visits, whether there's any difference in patient outcomes. AHRQ published a paper, I think last year, and it was kind of a redo of 2 other bodies of work that they have done. And it does show that the outcomes are equivalent, but I think people want to know, okay, but what about now? And I'm sure there are other things that are not on the sustainability list. In the interest of time and the lack of interest in having a discussion, I think what we'll do is kind of breeze through questions. And one question poll, we would love to hear from you about whether this was helpful, not helpful, was this too much of a talking head, was it, whatever. We want to know, did we waste your time? Did we not waste your time? Was it valuable? Maybe it was valuable. Could take it or leave it. Valuable or extremely valuable. We appreciate your letting us know. The results are anonymous, so you can say whatever you like. We'll take that to heart, and if you give us a 1 or a 2 or a 3, we'll endeavor to be far, far better next time. And make sure you register and attend the NRTRC annual conference. I've seen the agenda. It's amazing. The lineup is stupendous. You will love it. So make sure you sign up and attend, and I hope to see you there. Before we close, is there anything else in chat that I need to know? Jolene, Nikki?
Nope, I think we're up to date. I think we're up to speed. So thank you, Trudy. Some thank yous in the comment box and the chat box, but some really great information today. So we really appreciate that here at the NRTRC.
Great, everyone. Have a really super duper day. Bye-bye.
Bye, all.